like to welcome our speaker, Dr. Rae Wright. I'll go ahead and read her bio real quickly, and then she can bring up her slides. Dr. Wright grew up in rural Eastern Kentucky and graduated from the University of Kentucky College of Medicine in 1990 and completed her family medicine residency in Ventura, California. She is boarded in both family medicine and addiction medicine. She has worked with the WWAMI Family Medicine Network Faculty Development Fellowship on curriculum development for 15 years and currently serves as the Associate Director for the Fellowship, which serves over 30 programs in the Northwest. She also served as the Associate Program Director at Peace Health Southwest Family Medicine Residency Program for over 15 years and remains the Addiction Medicine Fellowship Director for this program. More recently, Dr. Wright was named to the STFM Task Force for Competency-Based Medical Education with funding from the ABFM. She spearheads this group's effort in the development of assessment strategies to meet the new ACGME and ABFM requirements. So with that, Dr. Wright, go ahead and take it away. Feel free to share your slides at this time.
All right, thank you so much. Okay, so today's talk is really was initially designed to talk a lot about ILPs and a little bit about coaching, but it turns out you will have an excellent talk next month that will focus on ILPs. So we've decided to sort of refocus a little bit in how we spend our time today. So it's really going to focus more on the coaching aspects of things. So our objectives are to go ahead and review at least the essential components of an individualized learning plan, to talk a little bit about how an ILP is different from a remediation plan, to talk about the various faculty roles in mentoring, advising, and coaching residents. And then I'd like to introduce a model for coaching for change called the R2C2. And so we'll go through all of that together. So for ILPs, I started when I gave this talk the first time by just going through the ACGME requirements and doing the search for the terms ILP, learning plan, and individualized learning plan. I sort of came up, what is ACGME saying about learning plans? And so this is what they say. So first of all, it's a critically important tool for all residents and fellows to take into account individual strengths, goals, and the requirements, and to identify what is needed in terms of personal adjustments and resources. So that's how ACGME describes them. And then I was going to do this as a poll, but there's not really very many of us here, so I'll just ask, are the participants here now, are all of you using ILPs at your program? Have all of you participated in an ILP? Yes, we're using ILPs. Okay, good. Yeah, and I think that's it. Most programs, that's become sort of a standard part of it, but not every program is using them in the same way. And some of that's good. That's a natural part of the diversity of different programs, different strengths and needs. And some of that may be a misunderstanding of what the intention of an ILP is. So we'll talk about both of those things. All right, so what else does ACGME say? So they say that the IOP has to be done at least annually, though I think most programs do it more than that. It has to provide a system for tracking and monitoring progress. The program has to provide that. The program has to provide faculty mentorship to help residents create learning goals. So that's part of what today's faculty development is about. And it also says that electives should be driven by each resident's IOP. So elective planning is a big part of the individual learning plan. So what do I mean by differentiating between an individualized learning plan and a remediation plan? So remediation plans are really about once a deficiency has been identified and responding to that, whereas a learning plan is about preventing a deficiency. And the reason this differentiation is important is that a lot of programs used individualized learning plans already before this became like a big CBME thing, and ACGME was promoting it, and they were using them more as sort of a precursor to a remediation plan. And that's what I'm trying to help programs rethink that model, that individualized learning plans are really meant for all residents, your STAR residents, your average residents and your struggling residents, that everyone needs to start their residency or soon thereafter with an individualized learning plan that progresses as they progress based on what their individualized needs are. And when deficiencies are found, if they can be within the structure still of an individualized learning plan, but if there's something where the program really needs to be monitoring this and it has a lot more input and structure into how that it's doing that's coming from the program, then that is a remediation plan. So the remediation plan is only for those learners where the deficiencies need extra help that is more program driven. Learning plan is for everyone. Remediation plans are really focused on training requirements, whereas learning plans are also focused on professional well-being and guidance towards those long-term goals even after residency. Remediation plans, again, are focused more on the gaps, and learning plans are focused on the goals. But where are they alike? So they're alike in that both of these are about finding ways to improve. It's just sort of where the resident is in that trajectory and how much of a prerogative is theirs versus the programs based on the need. And both require concrete benchmarks of achievement. And that really means SMART goals to me: specific, measurable, achievable, relevant, and time bound. So what else? ILPs should prompt reflection on the part of the learner. They should be competency-based in their goals as well as SMART. There need to be strategies to achieve those goals. It's one thing to have goals, but how are you going to meet them? What does success look like? There should be ongoing revision. So the residents should be looking at these periodically with or without the faculty, but the goals should be done in collaboration with faculty. And where do milestones fit into that process? Well, milestones are also considered formative, and ACGME says that they should be used to identify learning needs and lead to a focused or general curriculum revision, which we talk about a lot, that milestones are really about promoting program change. But the language within the milestones is actually meant to help the resident and the faculty or the program identify sort of where they are more likely to be in a progressive manner. So individualized learning plans, it's really helpful to use the language from the milestones. If a resident's struggling to figure out where are they, where should I be, what level am I now? And if you're an R1, it can be helpful to refer back to those milestones and look at level 1 and 2 and say, well, you really should be doing at least this and progressing towards this, not as an assessment tool, but more as a reference tool. So what about outcomes? Where do outcomes fit into this whole model? And so ILPs are meant to target. Outcomes are really at the end. And so, but you need to be making progress. You want to identify where your residents are along the way. If the graduation target is competence without need for supervision for those 15 outcomes, then the resident needs to be making progress toward that. So you're not telling them at the end, whoops, no, you didn't quite make it to this particular outcome. That should be being addressed with the progress towards that. And the ILP is a great way for them to address that so that they are really the ones driving how they're going to get there. Progress toward outcomes, ABFM recommends that get addressed at least every 6 months. So that is one good reason to look at ILPs at least every 6 months, and then address, like, again, the progress towards those outcomes in addition to their other goals that they're recognizing that are more personalized and individualized towards them. It's an iterative process. So for ABFM, at least the first set needs to be created within the 6 months, and then it continues to build on that progressively. And the follow-up, the residents should be looking at these much more frequently. And then many programs have moved toward quarterly meetings, again, to help residents so they don't get off track. Because as we all know, it's really hard on our residents and on our programs when our residents are sort of off track and you're worried that they're not going to be successful in some rotation or some skill set. And it can be really challenging to get them back into the mix and not have them feeling like they're more of an outlier than they need to be. If it's identified earlier, it can be addressed earlier, and hopefully progress can be made earlier. So what are the challenges with ILPs? And so what do you think are the biggest challenges with ILPs? Do you think it's the residents' inability to self-reflect and set goals, or that their goals are just not consistent with the programs, or you don't have opportunities in the program to meet their goals? Which of these do you think, or more than one of these, do you think is the most challenging?
So the most challenging thing for me right now is that we are trying to get our program going and we don't have residents yet. And so I've just been kind of filling this role and learning as we go. And so that's why I'm here, is just to listen and learn. I don't really have too much feedback on this. Because like I said, I haven't done any of this yet. I'm just here to learn.
That's really helpful information, and so I would say the most important thing about these challenges are going to be what things that you can work to avoid. So first of all, to address a lack of experience in meaningful self-reflection and goal creating, is to do actual teaching sessions for both the faculty and the residents. It's one thing to do faculty development, but if the residents don't really understand what that means, if they don't really understand what self-reflection is, what's expected of them, then it's going to be much more challenging. And also to that idea of assisting them with goal settings, that just having the resident articulate their goals either verbally or in writing without someone mentoring that process, then the goals are not as meaningful. So you want the goals to be resident driven, but it needs to be supplemented with what kinds of things are showing up on their evaluations, and then lead them to come to the conclusions about how to fix that. And of course, if the resident wants to be able to do, like in our program, residents really want to do vasectomies, but if nobody in your program does vasectomies, that can be a challenging thing. So being realistic about what the programs can facilitate is also really important. And then also following up to track progress. If they have this goal, when do they think they can meet it? What is their realistic projection from that? How much time is it going to take? And then finding faculty mentors that really vibe with the resident can also be challenging.
Dr. Wright.
Yep.
I just had a comment too, because that was it letter C, opportunities.
Yeah.
I know, especially rural, they might not have access to all the different types of rotations or experiences, or maybe that one preceptor isn't available for like this rotation at this time. So I know we've had to do a lot of like juggling just to balance that, and just, again, with the follow-up, making sure that they do get that at another time. I know has been one of the challenges that sticks out to me.
Yeah, that makes a lot of sense, because not every program is resourced in the same way. And so I think that's one of the other values of collaborative networks of programs that can help that. And also, I think that's where the faculty comes in to help set realistic expectations. So it may be that the goal that they have needs to be modified in some way in order so that it can be a realistic goal that the program can facilitate. And some goals are better met outside of residency. We're all continuing to learn forever, and so there'll be some things that residency can provide, and some things that might happen in that first job as well. And so just being able to help the resident recognize that, and maybe to augment what their goals are with something that is that the program can satisfy, especially in less resource intensive areas. Thank you for that. So one of the things, in order to help the resident set the goals, this is where coaching comes in, and coaching can be different things. It can, in its purest form, coaching is outside the whole idea of the evaluation system. That it's really, you would have a coach that can teach to a particular skill or subject to the partner with the resident to maximize success, but the coach is not someone who's also evaluating the resident or advising the resident. That it's different, that it's this neutral process outside the evaluation process. For instance, in a pure coaching model, a resident who was looking to improve their history taking skills in order to connect better with their patients, or perhaps with agenda setting or something like that, then you would have a coach that's not necessarily directly affiliated with the residency program, who that they could then meet with, and they would work on that skill set, and they wouldn't be getting evaluated during that process. So that's kind of the purest of the coaching models. In coaching, one of the most important things is that expectations being clearly defined. What is the learner trying to accomplish, and what can the coach actually provide? And setting that up front is really important. The coaching model is very much learner driven. Again, it's the learner that's saying, this is what I want help with, and then working with the coach to come up with a strategy to get that help, rather than a model where the program is saying, you need to work on this and this is what you need to do. So coaching is really more about helping the resident learn how to get to where they need to be. And it really focuses on the strengths of the resident or the learner in order for them to achieve those goals. So that's a purist sort of version of a coaching model. And then I cut and pasted this from the AMA has a coaching in GME handbook. It's about 50 pages long, but it's really good. And so I would highly recommend, if you want more, if you want to develop skills in coaching, that's where a lot of this information comes from. And so in this model, the other really important term is master adaptive learner. So a master adaptive learner is part of competency-based medical education. If residents aren't capable of getting where they need to be in a way that is driven by them, then their ability to progress through residency is going to be hindered. And even more importantly, their ability to keep up with things after they leave, which those of us who've been around for a long time recognize that's changing way quicker than it was when I graduated from residency. That there's so much to know, there's so many different skill sets with AI and everything else. And so we need to teach our residents to be master adaptive learners so that they can learn and adopt these new skills in a way that's not so stressful. So when we talk about that in terms of coaching, then again, it starts with planning, building that relationship, getting to know the resident, what is going well, talking about how they're going to get to where they want to be, what are their strengths. Not every resident is going to get from point A to point B the same way, and that's okay. But really should be making sure that we're paying attention to what their skills are and their individual needs are. Also, getting their self-assessment, where do they think they are? Because that means a lot. And then figuring out, okay, well, you say you're here, but sounds like to me you got some evaluations that said you're there. Where do you think that discrepancy is? And then helping them work towards a way to sort of bridge that gap. So that's part of the whole master adaptive learning process, and that's where coaching comes from. And so how does a coach, or how do coaching skills differ from being an advisor or a mentor? And this graphic sort of spells that out a little bit, that again, the coach is really, the learner is the driver. It's what they want to get better at and how they're going to get there. It's just being facilitated. The advisor is actually driving the conversation a little bit more. So the advisor can certainly use coaching skills, but they're not exactly the same thing. And then the mentor is meant to be on the other side, where that's just where the resident would go and ask for advice, and the mentor eloquently talks to them about how they need to get there. And it's more driven by the mentor's expertise. So, but these terms really do cross over quite a bit. And so an advisor versus coach versus just plain old advisor. So and both of these need to be looking at things like outcomes, and not just the 15 outcomes, but outcomes in its more traditional sense of where are they trying to be, what outcome are they looking for. whereas the coach is doing more of the negotiating with the resident to get them where they are, and a traditional advisor role is working at more directing what they need to be doing. And then there's this really opportunity zone, and that's why coaching and ILPs are so tied together. That if it's the resident's prerogative, if whatever issues that they're dealing with are still reasonable for the program to not be too hands-on, let it stay there. If the resident can actually own it and come up with plans and goals and a strategy to meet that, they will be much more successful. So trying to find that place where you're using coaching skills as part of the advising process rather than just top down telling residents how to get where they need to be, engaging them in that process in a more intentional way is the goal. So what do I mean by negotiation? So some examples might be that phrases that you might use, or I notice you didn't mention the outcome data from the CCC. What might incorporating that into your goals add, if anything? So this is meant to reflect some statements that can be made in the context of mentoring a resident on their ILP. Again, it's more asking questions, so the resident is coming up with the answers. And it's like, I really noticed that this is a strength of yours, but and that's great, and validate that, but then to move on to, oh, but it looks like some of your evaluations are saying this. So how can we incorporate some goals into your learning plan that also address what you want to address, but also address areas where the program has perhaps noticed weaknesses. So again, this is when you're using the principles of coaching to drive improvement, rather than having a pure coach who might be outside this process altogether. And I think for most family medicine programs that are outside of a large university setting, or are more peripheral to the large university setting, they're going to have a hard time getting pure coaches who are not also either advisors or evaluators in some other setting. And so utilizing coaching skills in that context is still okay. But if you can get an external coach, that's always the ultimate goal. And then the advisor can just focus more on whether or not they're successful. So part of this also is empowering the resident to, and a lot of times when we're trying to do this, it sounds good, but then the resident they're just not used to driving the conversation. And so their answer might be an I don't know. And so push them on, well, how do you think you could get better? What are some strategies you've used to get better at other things? What about strategies that you've used to improve? Perhaps they're an athlete. Talk about, what are some of the challenges you had when you were playing basketball in high school? How did you get better with that? So helping them identify where their skill set is and how to think about self-improvement. And don't give them your ideas immediately. At least with me, that's so hard. I have so many great ideas, and all I want to do is fix it for them. But in the end, it makes it, just like parenting, it makes it harder to fix themselves. And for any residents who might be watching this as a recording, I think that you recognize that as well, how much more successful you are in life in general, and residency is no exception to that, when you're driving your avenue towards improvement. So now I'd like to transition a little bit to this idea of the R2C2 model. And this comes from ACGME. So if you were to Google ACGME R2C2, you would have a whole host of resources available to you for coaching. And this model of coaching is really meant to be incorporated into advising and coaching model, as opposed to the pure coaching model that might lie outside that framework. So the R2, the first R is rapport building. Again, going back to what we talked about with coaching before, this idea of that needs to be mutual trust between the two. The second R is the reactions to whatever feedback is being discussed, and allowing for the resident to express that openly without judgment, and then moving towards the content of the evaluation process that you're going to be looking at together, and then incorporating these coaching strategies within that. So let's talk about each of these a little bit more individually. So for the rapport building, so the goal of rapport building is to engage the resident and build that relationship of mutual respect and trust. Then how do you do that? And it really starts with, first of all, just setting those expectations from the beginning. This is why we're meeting today. I've had a chance to review your evaluations. Have you had a chance to do that? How are you doing in general? How is residency treating you? Really seeing where they are, giving them a safe place to express that can go a long way towards the rest of that conversation. And then moving to outlining the agenda about what you're going to be doing today, that you're going to be looking at the assessment data. And then if they have already looked at it, seeing how they're feeling about whatever their initial impressions are to that information before you start digging into it too deep. So that's kind of the beginning of the rapport building. And then you're going to get their reactions, and oftentimes it's not what they expected. So just calling that out from the beginning. Was there anything that surprised you? And asking them to elaborate on that, about what they were surprised by. And that also helps determine what those gaps are between what the program's impression is and what the resident's self-assessment might have been. And that can be, pretty painful to see, if you think that all your patients love you and then they get the feedback back that, wow, they're in the bottom quartile on their patient assessments. That can be hard to take, and there can be some defensiveness there. And so, but it's okay for them to feel that way. We all feel that way. And so just validating what their feelings are, even if you're not validating their opinion, but their feelings should be validated. And just recognizing that it can be hard to take feedback, especially, doctors are very high performing people who've spent their whole lives doing well in school to get from one point to the next. And so I think that we don't receive feedback as well. We feel like that feedback is criticism, and somehow it's going to stop us from, getting into medical school or getting into the residency we want. We've been sort of conditioned to think that way. And so helping them get past that so that they can actually own their opportunities for improvement, because none of us can grow if we can't really identify where those growth opportunities lie. Amanda, were you going to say something?
Yeah, so I love that piece. We're going to work together because that just helps establish the rapport, even though it might take time, and everything you just said about the culture sometimes in residency. So I think reiterating we're going to work together is important.
Yeah, and I think that and making that actually true. It's one thing to say it, but to really, let the resident know, I'm not here to give you this feedback and then to put you under a microscope going forward, because this has been identified, and just then to continually assess. You're still not doing it. You're still not doing it. But it's more like, wow, okay, this is where you want to be. Let's talk about what that looks like. And working together to get there, so that you really are in this together. Their success is your success. And that is a culture change, not just for residents, but for faculty as well, I think. And so then once you've, you sort of spent some time connecting, demonstrating and discussing how you're in this together, then it's time to start looking at the content more specifically. So, it's starting out more just getting their gestalt about the content. And one of the most important things and this is that for you to have really looked at it yourself, and not to show up unprepared when you're meeting with your residents. And, if you've just scanned it and you're just sort of going to look at it with them when they're there, that's actually not very helpful. It really does make a big difference if you've had a chance to really look at it and to think about it, so that when when you're talking about it, you're an informed participant in this conversation. So the goal is for the resident to be clear about what the assessment data mean and the opportunities that are suggested. And the opportunities that are suggested are often already within the evaluation report. And so they don't really need you to give them a lot more suggestions often. They need you to help make sense of the suggestions that are there and to see where those can be modified to fit the resident needs or to facilitate them coming up with ways to meet that. So having the data available so that you can specifically look at it with them and asking them if there's anything in the report that didn't make sense to them. There's often comments in there that we're terrible at making comments, and you could do a whole talk just on how to write a good comment. And that's what residents really pay attention to. You know, resident needs to read more as a comment is not particularly helpful. Read more about what? And what does that mean? Or residents' communication skills need work. What communication skills? You know, is it that is it their body language? Is it the words they use, or are they using too much medical jargon? Are they not asking the right questions? You know, what is it very specifically? If you can't articulate it, they can't understand it and improve on it. And so and this is a good time to, if the resident says, I have no idea what this comment means, you may not either. And that's okay. Say, well, let's find this out together. You know, why don't you talk to this person and see, you know, and I'll help you set up a meeting and sort of maybe get some clarification about what that is. Or maybe you do know because that person has talked to you and you can help elaborate on that, but also empowering them to talk to the people who are doing their evaluations whenever possible. And then actually going through it section by section helps identify trends. One-off comments are not that meaningful, honestly. There are personality clashes, there are bad days, but when you go through it together, you'll often notice that there's some kind of trend, and then hopefully the resident will identify that, or if not, you can help them identify that, and that might make it more meaningful to them. And then starting by what, you know, if there's, especially if there's a lot in there to unpack, let them drive the agenda about what to focus on. And it doesn't mean if there's big things that are safety issues that you think are really going to challenge the resident, you're going to come back to that because you have to. But oftentimes they'll also identify those same things. And so that allows them to have more ownership in the process. And you can always come back to the things that maybe they should focus on that they didn't initially focus on. And then so that's all of that is really before you even get to the coaching. So that's just setting up for coaching success, you know, building a relationship and looking at the content in a really specific way, allowing them to express their feelings and their reactions and ask questions about the interpretation of the content and clarifying that. All that needs to happen before you can actually get to a place where you can help them improve. And so if they don't accept the content of their assessment, then they're really not going to change. And maybe that's okay. Maybe it's not a big enough deal and you want to move on because there's multiple other areas that you want to work with the resident on. And so you do have to pick your battles sometimes. And maybe some of the things you can come back to another time. Because I think we've all had times where we like, oh my God, you know, you talk to the resident for 30 minutes and they're fixated on something that really wasn't that big a deal to begin with, but you never get past it to get to the stuff, the meat of it. Try to avoid that. And again, that's why it can be helpful to let the resident drive the conversation. If you talk about things in the order they want to, you'll get through more things. So again, consider coaching as more of guiding the development of goals and activities to achieve them rather than giving them. Say, this is what you need to do. Ask them, this is what the feedback you've gotten is. What do you think you need to do that? And then it's a lot like motivational interviewing, really. You know, getting the patient to come to the way that they're going to change their habits to help their diabetes is a lot of the same skill set that you're using here. So we know how to do this. And then also anything that they can own so that it's not the program, because we only have so many resources. In our faculty, there's only so much faculty. And so anything where the resident can actually own the work involved to change is also really important. And then making sure that there's that concrete plan again developed. The idea that that it's very specific what they're going to do, that you can measure whether or not it was done, that it's achievable at your program, you have the resources to be able to do that, that it's relevant to the issue at hand, and that there's some time follow-up to see if any progress has been made. So I wanted to sort of walk us through a case and think about coaching a little bit. And this is a case that I adopted from the ACGME coaching for change modules, but and just sort of abbreviated it for the purposes of this. So Matthew Smith is an R2. He's meeting with you as his advisor today for a quarterly review. Pretty typical thing, whether that be to talk about his ILP or it's just this, or maybe the semi-annual review. But this a routine scheduled meeting to review the evaluations that have been done so far. And the feedback that he's gotten so far is that he's a good communicator. He has clear, comprehensive presentation, so that's all good. But some patients and staff have seen him as sarcastic. Other staff members think he's arrogant and critical. There were comments on his 360 eval that he's not very respectful of his elders, whatever that might mean, right? And professionalism, that he tends to be late or doesn't always request supervision when he probably should, that there were some doubts expressed about his medical knowledge, but then at the same time, they say he's very committed and works long hours and gives the impression that he can do it all and wants to take ownership of things. So there's some good mixed in there as well. But as you read through this, and if there's anybody that's going to do this as a recording, just think about the picture you're getting of this guy, Matthew. You probably know him in your head somehow, right? That there's somebody that this fits. And then the next set of evaluation you're looking at is that what did the 360, the people who filled out the 360, what did they think he should do? Well, they thought he should come more prepared. They thought he should be more respectful and just ask for supervision when needed. And that's great, but those aren't really that concrete. What specifically would he need to do to prepare for the outpatient clinic? What are the behaviors that he's exhibiting that makes them think he's not respectful? Something that is that he can actually change, because if there's not an opportunity for him to get better, just do better is never that useful. And then asking for supervision when needed, providing an example when that didn't happen. So all of this feedback will be much easier to process together when it's more specific. And so sometimes if the advisors had a chance to look at this ahead of time, they can actually go back to the people filling out the form and get more clarification and information before they even meet with their advisee. So then the next evaluation that was looked at was that from direct observation. So looks like they had a direct observation on procedures that went well. There was some comment made about paying attention to the patient concerns and emotions. So kind of, is that a part of a pattern that you might have thought about from the 360? Their outpatient clinic thought to have gone reasonably well, but there was a comment about paying attention to statements you are not entitled to make. I mean, that's really vague, right? And I think that trying to sit down and process this feedback with the resident without more context is going to be challenging. So again, I think it illustrates the importance of reviewing the content of the evaluation before you meet with the resident so that you can talk about what it means rather than maybe debating what it might mean. So since Joy, you're the only one here, what are you thinking about this guy, Matthew, so far? What was your sort of thought about this guy's personality is probably like?
Well, my thought was that he's probably immature and doesn't have a lot of experience. and does, it needs to read the room a little better.
Yeah, I think so. He doesn't have it gives the impression he doesn't have a lot of self-awareness.
Right.
That his behaviors and the way he makes people feel don't seem congruent. So let's dig down a little bit more. So he did a self-evaluation, and this is what he said on his self-evaluation. I'm dedicated, my knowledge is good, I practice evidence-based medicine, and outpatient clinic is going well. And for his opportunities that he self-identified on his self-evaluation was under stress, my communication skills are not always up to the mark. So that's a great thing to explore. It can be really helpful to see what he means by that and see how that ties to what the other evaluations are. That his outpatient clinic often runs late. But look at this, they expect me. He sounds very defensive, even in his self-evaluation, right? And where is that coming from? And that would be a really, again, rather than jumping on that, it's just asking more about that. Tell me more about that. Yeah. And his communication, cooperation, professional are going well. My time management needs some work. So he is a little bit cognizant of things that are, but there's also a defensiveness in here. So knowing that going in can be really helpful in a coaching session to build on what they have already said about these things and exploring that with them. So how might we approach this and think about what are some of the questions that we might ask, and just sort of think that in your head to start with about what are the opening questions that you would have to build rapport? What are the questions you might have to get them to reflect? And then what content do you think that you want to focus on, recognizing that you want to focus on the content, ask them first, and then how might that facilitate coaching? So just thinking through those things. Again, sort of the reminder, the rapport, reactions, content, and coaching. And so I sort of put this together in my mind that we're really going to start with the resident's perspective and feelings about, have you had a chance to review your evaluations? How does that make you feel? What did you think about that? Were there any surprises? Validate if they're a little angry, or they're really surprised, or they're hurt, or they're frustrated, whatever their feeling is, validating it's okay to feel that way, and to reassure them, as Amanda said, the importance that you're going to help them with this, that these are not insurmountable, that they're not the first person to experience this. Clarify expectations, making sure they don't feel like they're in trouble, that this is not a session to tell them how bad they are and that they're in trouble. It's really a session to identify just opportunities for improvement that they may not have been able to recognize, and even being, talking about that. If they get too defensive, don't try to go on offense. If you can, just sort of lean into that a little bit and see where that defensive is coming from, and it wears them down pretty quick if you do that. Review the feedback specifically, sort of line by line if you can. Again, letting the resident drive that as much as they want to, and allow their perspective as you go before offering your perspective. Avoid offering your perspective if you can, and maybe help facilitate them reframing their own perspective instead whenever possible. In the end, you may have to find common ground. So with this resident, there are some of the things that he recognized on his self-evaluation about time management that was also mentioned in clinic. That's a good place to start because he identified it, they identified it. And so finding those areas where they have more insight will probably be good places to start, and you'll probably be more successful. Letting the resident take the lead in coming up with the plan, and then you facilitating, making sure that the plan is a reasonable plan that's going to be useful you might need to augment their plan a little bit. Or if their plan is, I don't think I need to do anything, I think everybody's wrong, then at some time you might have to be a little bit more didactic in your suggestions, but trying to avoid that whenever possible. And then part of that is challenging those differences with questions before just redirecting in a way, because it can be so frustrating, when the resident really doesn't have insight. And once that frustration becomes obvious, it really makes it hard to move forward. So the more questions you can ask, the less you'll probably be frustrated, and the more you will promote some self-reflection. And then get their commitment to whatever their plan is going to be with the follow-up plan. That is that sort of SMART kind of plan. So that's the R2C2 model that incorporates the principles of coaching with the directive we have for competency-based medical education. Residents need to be competent to independently perform a certain set of skills, at a minimum, those skills articulated by the American Board of Family Medicine, the 15 outcomes. And our role as a program is to help get them there. And the best way to get them there is in partnership, not as a program-driven thing. So all this fits together, and this is where ILPs, which we'll learn a lot more about next month, fit into this equation. Individualized learning plans that are resident-driven, having that model just built in, forcing us to build that in, I think is a really great thing. And will work in our best interest as programs as well as for the residents. The last two things I'll say is document these discussions really clearly, and have the resident verify that what was said, or you can have them do the documentation and you do that. But it does need to be documented with a follow-up plan and what is expected at that follow-up that everybody has agreed to. And so if there are any questions for my small group here, I also want to give a shout out to a doctor named Tanya Kaler, who is a professional coach. And I stole a couple of her slides, and she also has just been a great mentor to me. So I wanted to call that out. So any questions on this content?
I just want to say thank you a lot. This was really good and informative, and helps me understand my role more with the residents as well, and that I can build rapport with them, and that my role is important. Sometimes because we don't have a program and stuff going, I just feel like a little bit like I don't know, just disconnected, I guess, maybe that's what you could say. But I really enjoyed this. This is very helpful. I do have some experience in motivational interviewing as well. So this is great. Thank you so much.
Oh, well, thank you for saying that. And did you notice the parallels between the two, between coaching?
Oh, absolutely.
Yeah. Good. That's great.
Dr. Wright, I had a question.
Sure.
Opinion, at the core, what makes someone a good coach? Because you mentioned connecting with residents about sports, and I've often thought that the best players don't always make the best coaches.
Absolutely.
So I was thinking, what would you say makes someone a great coach?
Yeah, I think that, and I think you nailed it too. You don't have to actually be a family physician or a physician at all to coach. I think that a good coach is a good listener. And it's not only connecting with that person, but really being curious. What is this person? What's driving them? What does success look like to them? What are their fears? So really being a good listener to get at who this person is and where they want to be. And some people, naturally, that's who they are. And other people really just want to give advice. And I think that the people who are more curious are better coaches.
I guess another question I have would be, how would you, because one of the things that we also try to do is motivate, current residents to take on leadership roles. So how would you encourage residents to start adopting this maybe in their own interactions with others, maybe third years with first years, that kind of thing?
Yeah, I think one of the things that I've seen a couple of programs do and have done so successfully is that they do a didactic session just for the residents, and then they match up the third years or the senior residents with the interns, and they coach on something. And so the idea is that the one of the residents, or it can go back both directions too, but that they identify something they want coached on. It can be anything. It doesn't have to be anything to do with medicine. You could say, I really am struggling with getting keeping my dishes washed at home. I'm overwhelmed. So I need some coaching to figure out how to get past this. So it can be anything. And then have the other person sort of talk them through it using this strategy. So I've seen that exercise used a few times, and I participated in it once at a faculty development session, and it was really fun, actually.
Just a comment, I really like how you highlighted like the resident-led aspect. I think that helps bring kind of an open-mindedness perspective, and not these critical conversations don't have to be so critical and so punitive. It's working together to improve. And I think that's a great point in all this thinking about coaching and stuff. And yeah, thank you, Dr. Wright, for this session. Really great session.
Yes, thank you very much.
Well, thank you so much for having me, and let me know if any other questions come up. You're welcome to give my email to anybody who wants it.